All right, let's just briefly recap what we've discussed so far, and then we'll get a sense of what this debate is sort of shaping up to be all about. And then we'll move on to taking a look at Drain and Coulihan's discussion of medical futility. They think that the concept is sort of misunderstood in certain ways, and they also have a pretty surprising view about what a physician's obligations are with regard to fetal care. But so let's just sort of recap, make sure everybody is on the same page with what's going on so far. We've seen an argument from Murphy that physicians should unilaterally decide when a treatment would be futile and not be provided. And that was sort of based on physicians having certain kinds of unique qualifications and also benefits to family and better use of resources and that sort of thing. Now, Younger pushed back against that by suggesting that, look, this is going to involve value decisions that physicians aren't really properly trained to make, and maybe we shouldn't be asking them to make. And instead, what Younger advocated was a strategy of encouraging patients and families to agree to termination of care on their own. So we sort of try to educate them in certain ways to help them to understand the sense in which care is futile. One thing, again, that you should think about when you're watching the film is how successful that effort is, because one thing you'll see is physicians trying and trying and trying to explain to patients in sort of a careful, emotionally sensitive way that that treatment isn't going to work for them, and you'll see the extent to which this is not effective in these kinds of cases. And then we concluded with Miles's discussion of a particular case, the case of Helga Wangley, who argued that when we, and really what Miles asked us to do was just rethink our understanding of patient autonomy. That, look, patient autonomy does not mean that patients have a right to whatever treatment they want. It would be crazy if it did, and that would impose just a ridiculous obligation on physicians. And one of the things that patient autonomy doesn't entitle a patient to and doesn't obligate a physician to provide is care that's medically inappropriate. And he thinks non-beneficial care is medically inappropriate. That's something we should continue to think about in the case of Helga Wangley, because on the one hand, it's non-beneficial insofar as it doesn't, respirator support doesn't treat her underlying condition. On the other hand, it does prolong her life, and you might think that if there's anything medicine ought to be doing, it's prolonging lives. So that's kind of what we've seen already. And in general, I think this suggests a couple of just general threads in the conversation about medical futility. On the one hand, it is very difficult to see any medical benefit to treatment for patients where treatment is deemed to be futile. Even in these cases where life is prolonged, I suppose I just sort of suggested that that's technically a medical benefit, but you might be suspicious about that, because really when we talk about prolonging life, we're not talking about prolonging sort of vegetative life. We're talking about prolonging life of a certain quality. In addition, it's not obvious that patients are entitled to whatever treatment they want. In fact, it's pretty clear that they are not. And this stuff can be this shit is expensive, as I put it here on the slide. We're talking about some of the most expensive and least sort of rewarding treatment that we can pursue. It's a major burden on our healthcare system, and you might think that, look, for those sorts of reasons, we ought to think seriously about not providing care like this, even if people ask for it. On the other hand, decisions about futility and termination of care do seem, at least to me, and maybe to some of you too, like the sort of decisions that ideally ought to be handled by patients and families, and not by physicians. That this isn't the kind of thing that we want physicians to be making choices about. That raises all sorts of slippery slope worries. We don't want physicians to have this kind of absolute power over life and death decisions, at least not to this magnitude, not to this extent. We want them to sort of advise us about the medical facts and let us decide for ourselves. We don't want them to have the kind of unilateral authority that Murphy is talking about, certainly. And I think we can also acknowledge that physicians probably do make value judgments as a kind of unavoidable feature of medicine, and they really aren't trained to do this, right? You'll see you get quite a range. Probably some of you have noticed this in your own experience with healthcare. You get quite a range of sort of ethical sensitivity among physicians. Some are very, the AMA says X, therefore X, and some are critical thinkers. They think seriously about why we have these policies and whether they make sense and whether they ought to be criticized or challenged and that sort of thing. But none of that is a result of specific training on this, right? That's just not. It's really not part of, other than maybe a medical ethics course. Physicians receive very little training on this, on how to make value assessments well, how to sort of do that properly. Okay, so that's kind of a general, here's what we've talked about so far, and here's sort of the frame of the conversation so far. Drain and Coulihan are going to push a little bit deeper into the theoretical territory, and they're really going to push on the idea that this is really about a conflict between beneficence and autonomy, which are two sort of important values in medicine. So let's talk briefly about each of these. When we talk about beneficence, the idea here is that, look, what physicians should do, ideally, is apply their skills and talents for the sake of promoting the patient's good. They should avoid harming the patient in certain kinds of ways. And you might think that that includes a duty to refrain from providing futile treatment, especially when that treatment is harmful, sort of because it's painful, and also when it's not likely to benefit the patient. I mean, it doesn't sort of promote the patient's good in any sort of obvious way because it's by definition, it's non-beneficial treatment. Although, again, we can sort of quibble over what we mean by that. On the other hand, we've got this strong right of autonomy, which is that patients have a right to decide what treatment they do and do not receive. The most fundamental expression of that right is taken to be a right to refuse treatment, not to sort of demand whatever you want. But you might think, and most people would agree, that it's also a right to choose among futile care is medically justifiable. So we've got sort of competing threads here. We've got competing values in medicine, but duties of beneficence seem to push away from providing futile care, while duties to respect patient autonomy might seem to be pushing us in the other direction. And what Drain and Coulihan ultimately want to do is they want to really emphasize the value and importance of beneficence, because they think that one thing that's going on in our current medical environment is that autonomy and patient rights are treated as a kind of trump card, where if something is an autonomous choice, it has to be provided, and it sort of outweighs these other kinds of concerns, like patients want a treatment that's harmful or that's not going to benefit them. Well, if they requested it and they're autonomous, that wins the day. Autonomy always wins when we're trying to make decisions about competing values in medicine. And Drain and Coulihan think that this is really problematic. They think in this environment, other values really get suppressed, and one of them is beneficence. So basically what they're going to argue here is that whenever patients are making destructive or bizarre choices about their own care, that physicians are actually obligated to not provide that treatment. So physicians can refuse to provide fetal care because fetal care is actually bad medicine. Now, before we see the argument for that, let's talk a little bit more about what futility actually is, because they think there is actually some confusion about medical futility. They're going to try to push this by contrasting futility with two slightly different kinds of treatment. They said, look, futile treatment is not treatment that's ineffective. When we talk about a treatment being ineffective, what we're saying is that it's been statistically and scientifically determined that a treatment has a 0% success rate in a large number of clinical trials. They say, look, futile treatment is not like that. Okay, we're not talking about care that has been scientifically shown not to work. And we're not talking about just sort of highly improbable effectiveness, where a treatment is sort of occasionally effective but not reliable or predictable. That's not what we're talking about. Most of the time in futility cases, we're talking about treatments that are sort of the recommended established course of treatment for a particular condition. We know we've got empirical evidence that this treatment really does work and that it's worked over and over and over, that it's reliable. It's just that in a particular case, it's not going to do what we want it to do. And I think that's really what futility is about. They say, look, futile care is always somewhat effective, usually in physiological terms, sometimes also in terms of keeping patients alive longer, postponing their death and that sort of thing. But what makes it futile is that it fails to bring about a patient's medical goal or something that can be described as a real and legitimate personal benefit. They think, look, that's really what futility is about. So let's not confuse ourselves and think that we're talking about treatment that just doesn't work or that's highly unlikely to work. That's not what we're talking about. We're talking about these sort of special cases where certain medical facts make it the case that like the recommended effective treatment is not going to have the kind of impact on the patient's long-term goals or show real medical benefit. And they think once we get clear about that, we get a better definition of futility. Here's how they define futility. They say a medically futile treatment is an action, intervention, or procedure that might be physiologically effective in a given case, but it cannot benefit the patient no matter how often it's repeated. So it's not that it's ineffective, it's that it's worthless. So this is why the debate about futility is really problematic. I mean, you're not going to sort of get around it by talking about futile treatment as treatment that's physiologically ineffective or something like that, because those aren't the hard cases, right? Those aren't the cases that we struggle with. It's the cases where a treatment actually will do something in a physiological sense, but it's just not worthwhile. This is where these real value judgments come into play, and these are the cases that are really hard. Okay. One thing you should notice, too, about this, I think, before we move on to the rest of their argument, just notice that in Helga Wangley's case, this definition is going to imply that her care really was futile, because although respirator support was effective, and in general that's sort of a treatment that does what we expect it to most of the time, it wasn't worthwhile, right? It didn't sort of lead to anything good. It didn't fulfill some goal that Helga Wangley had. She lived for 7 months on a ventilator, and then she died of her underlying illness. Clearly, you'll also notice when we talk about treatment being worthless, we're obviously making value judgments. And Drain and Coulihan are just going to reject the idea that that isn't part of medicine. They're really going to push back against that and say, no. Physicians make value judgments all the time, so you don't get out of this by just sort of banging that drum and saying, look, physicians shouldn't make value judgments. We do that every single day. Okay, go ahead and move on to the question. It's about how we should define futile care according to Drain and Coulihan, just asking you to sort of paraphrase this definition, and then we'll move on to some of their arguments for a pretty surprising view.